Okay, well, that being said, let me
Oh,
take over the
let me
screen. Can
just
you?
let me just finish up with some introductions.
Oh, sorry, sorry.
Yeah. So just to provide a framing, I think one challenge we do face in healthcare as a field is seeing how AI can contribute meaningfully to the health of diverse communities and to close existing gaps in health equity. And what I find very inspiring about the story you're about to hear is how this remarkable team goes from a clinical problem that's rooted in a community's health needs and innovatively applies AI as part of a multi-pronged solution. So I'd like to introduce our speakers. Dr. Cesar Termulo currently serves as the Associate Medical Director and provides medical leadership over the central and eastern regions of community-oriented primary care of Parkland Health. This network is the largest public ambulatory primary care system in Dallas, serving a large population of diverse low-income patients. Before current leadership roles, Dr. Termulo spent nearly 20 years serving the Parkland healthcare community as a primary care pediatrician, starting from residency with travel on mission trips to treat people in third world countries, to his primary care work with the underserved inner city population of Dallas, to his present position at Parkland. He has strived to work within public health systems from both the frontline and administrative position to improve community health. And Dr. Yolande Pengetze is a pediatrician, physician scientist, and vice president of clinical leadership at Parkland Center for Clinical Innovation. She has over 25 years experience in clinical and healthcare leadership, leveraging advanced analytics, technological innovation, and care transformation to promote community health equity. And then our guest discussant today is Dr. Maya Hightower. She is the CEO and founder of Equality AI and former executive vice president and chief digital transformation officer at the University of Chicago Medicine. She's a leading voice of the intersection of healthcare, digital transformation, and health equity, and is a champion for responsible AI, ensuring that the digital future of healthcare is equitable and just. And at the heart of her mission is Equality AI, an early stage investor-backed healthcare tech startup. She's a four-time C-suite physician executive with 15 years of leadership spanning healthcare IT, medical affairs, and population health across academic medical centers and clinically integrated networks and accountable care organizations. So just a reminder that the next Aim High presentation will be August 8th at 12:30 p.m. And please join me now in welcoming Dr. Termulo and Dr. Pengetze.
Thank you very much, and I apologize for jumping the gun on that, but perhaps it's because I'm enthusiastic of the work that we do here at Parkland. I'm joined by Dr. Pengetze, who's the Vice President of Clinical Innovation at PCCI, and together we will present the generalizability of an AI ML-driven asthma QI program in our safety net system. So we know that asthma is part of the fabric of our healthcare system. There are 4.6 million children with asthma nationally, and that comprises 7% of the pediatric population. It generates 270,000 emergency room visits every year. And as per the CDC, there were 145 cases of pediatric mortality. And we know that asthma is a marker for disparity in our country, and that 3.8 million persons who have asthma, both pediatric and adult, live under the poverty threshold. And we know that the highest burden is among minority and low-income families, and that 12% of the African-American population has asthma compared to 7% of Latino and 6% of Caucasian. And asthma-related ER visits are nearly 5-fold higher for African-American patients compared to Caucasian, and deaths are 8-fold higher for that population as well. So I work for Parkland Health and Hospital System. It is Dallas County's only safety net system, and we are a large institution in that we have a hospital with 983 inpatient beds. We have over 60,000 admissions per year, over 230,000 ER visits per year, over 1 million ambulatory visits per year. We have 17 community clinics spread out throughout Dallas County. And we have established clinics in all the correctional facilities throughout Dallas County. We have 8 mobile vans that outreach to the homeless. And we also have 2 school-based clinics that are located on Dallas Independent School District campuses. As per all non-for-profit hospitals in the United States, we are tasked with performing a community health needs assessment every 3 years. And our first CHNA took place in 2016. And after the 2019 iteration of the CHNA, we established different initiatives. And one of them, we established this initiative to address pediatric asthma in our community. And in addition, we did establish other initiatives such as mental health, diabetes, breast cancer, postpartum mortality, and other very important issues that go on in Dallas County. And one thing that we found is that there were certain zip codes that were most affected, had the greatest pediatric vulnerability towards asthma attacks and ER visits. And those are the ones that are colored orange and dark red. And you can see that it is predominantly in South Dallas that the majority of pediatric asthma vulnerability takes place. And this mirrors a lot of the disparity that takes place in Dallas County between North and South Dallas. 9.5% of the Dallas Independent School District population does have asthma. So you can imagine that's a large number of patients that are going to the ER and a large number of patients in our community that could potentially affect our healthcare setting. So one of the greatest issues that we have in Parkland is that we have over 2,000 children who have asthma in our system. And providing good accessibility is a challenge because most provider panels in our clinics have about 1,500 to 1,800 patients per provider. A lot of my colleagues in non-Parkland settings, they might have 500 to 800 patients in their provider panel. But for us, giving good accessibility is a bit of a challenge. But not only that, a lot of our patients have social determinant of health issues that can negatively affect patient outcomes. So I know that when a patient leaves the door of my clinic, I might do the best that I can to educate them about their asthma action plan. I might teach them how to use a spacer with their inhaler. I might prescribe the appropriate anti-inflammatory control medication with their rescue medications. But at the same time, once our patients leave our clinic, oftentimes they may be in difficult living situations. They might be exposed to a lot of smoking. They might have transportation issues. They might have insurance issues to where they're not able to avail of the medications that I prescribe. So therefore, we have a very difficult situation in that a lot of our patients might not have optimal control of their asthma. So the opportunity presents itself that if we can use AI to provide timely diagnosis of rising asthma risk in our community and with the patient population that we have, and can we use AI and ML to capture those cumulative effect of multiple actionable risk drivers, so that if we can use AI to be able to find those patients who might need timely intervention before they get to the emergency room. So when we started our program, there were different tools that we tried to implement. The first thing that we tried to do is we tried to implement a risk prediction model. And Dr. Pingantini will be able to go into further detail about how it was developed. But we were able to try to focus and predicting within 90 days, will certain patients end up in the ER? And can we tier them into different levels of very high risk to medium risk? And we try to use clinical and SUH factors that might contribute to that tiering. From that risk prediction model, we tried to take all of our patients and we tried to develop monthly risk reports. And our clinical staff at Parkland would use these reports. But also we developed a collaboration with Dallas County Health Department. And Dallas County Health Department had community health workers that would call our patients who are most at risk for asthma attack and were most at risk on the monthly risk reports. So they would do asthma education virtually. They would also do education about their asthma action plan. And they would also do the asthma control test, which is a 5-question survey that gave a clinical picture on their status of whether the asthma is being controlled or not. So those patients who scored poorly on the asthma control test was then given to our asthma program manager. We have a respiratory therapist who will reach out to those patients and try to bring them into the clinic if they don't have an upcoming appointment. So in addition to that, we also developed a clinical workflow integration. So for a lot of our patients, if they do come to our clinic for issues unrelated to their asthma, a best practice alert might show up on the screen. So if I'm seeing a patient for a headache or for a fever or for ADHD, and if I did not know what's going on in the background, if they are at high risk of an asthma attack, a BPA would show up on my screen, and then I would know that I need to address that issue. So in addition to that, we also developed a text messaging system where we would engage patients to remotely monitor how they're doing with their asthma. It's very simple. They would only receive 2 questions. And the first question is, how is your asthma doing? And number 2, how many doses of control medication have you missed? So we try to make it as user-friendly as possible. But anecdotally, we have some success stories with that. We had one patient who has cystic fibrosis. However, they were lost to follow-up and they ran out of their medications. But thankfully, because they're part of the text messaging program, we were able to reach out to them. We were able to bring them back to one of our community clinics, get them back on the medications that they should be on, and then we were able to plug them back with their pulmonologist. So there's some good successes there. And then I think Dr. Pengency will talk about the asthma risk model design.
Thank you so much, Dr. Termulo. So that's a great setup, because we're going to dive into the specifics of the data analytics and the outcomes monitoring, but it's important to understand that big picture of us trying to target these low-income communities, safety net populations, with AI-driven models that helps providers and other stakeholders work in a coordinated manner to improve their outcomes. And again, like Dr. Termulo said, one of the steps, the first step was to build a risk prediction model that leveraged data that we could have in, access to, both from the hospital and from the different areas where we collect outcomes data, as well as SDOH data, to predict asthma risk, the risk for asthma-related ED visit hospitalizations within the subsequent 3 months. And again, we chose 3 months because it's a very clinically relevant interval. It's not too long to prevent a meaningful understanding of what the specific drivers are intervention. It's not too short either to prevent the ability to actually curb the trajectory of these patients. And what we did was we used a broad definition. We basically took any patient who had anything that was related to asthma, whether it's a visit, ED visit, hospital visit, outpatient visit, or any medication. And then when we apply the risk prediction model to that population, it sorts them out and can allow us to focus on those patients who are at higher risk for poor outcomes. And make sure that we use a model that is transparent, because at the end of the day, in addition to understanding what the risk level is for each patient, we want to understand what are the risk drivers so that those can be actionable and drive intervention. And in general, the model variables are in data that we know tend to have some association with asthma outcomes, whether it's the patterns of healthcare utilization, medication use, sociodemographic variables, systemic steroid use, and medical and psychiatric comorbidities. So this is what the model looked like. So to the right are the variables that are retained in the current model that is used, the EHR-based model. And again, like you say, you see ranges from medication use patterns to patterns of office visits or office visit missingness, no-show and cancellations. That's very important in a safety net population. Patterns of outpatient utilization, age, as we know, age is a good predictor of patients' outcomes with asthma, exposure to smoking or secondhand smoking, gender, in this case, Hispanic ethnicity, and to the right, some performance on the model. So overall, the model performance was good with a C-statistic of 84%, but more specifically, the positive predictive value in general was fairly robust across the risk categories, as well as the sensitivity, with an overall PPV of 13%, sensitivity of 52%. Now, we've looked at the literature and recently published data from, I believe, a team at Kaiser Permanente looking at a prediction model from Intermountain, actually had similar outcomes for their risk prediction model, but they were predicting the risk of asthma within 12 months. So, and the prediction within 3 months is actually more difficult. So having similar parameters of performance is actually encouraging. So we then pull these reports, and it's important to get those in the hands of the providers or the folks that can do something about them in a timely manner. So to the left are just figures showing you how on the top we actually build a master report, and then we split it by provider. So we have to have accurate provider assignment to ensure that we're sending the data to the right person that can do something for these patients. And then we made sure that the reports that we send them are actionable. That is information that if you gave a case manager, they would be able to act on. If you gave a provider, they would be able to intervene with. But the last figure 3 right there is some sort of a scorecard. And the goal here is to compare providers with peers, because we always have this feedback of making sure that we compare apple with apple. We want to make sure, so we would compare a provider performance. We looked at important metrics in asthma, like asthma-related ED visits over the preceding 12 months for the provider panel versus the entire population, asthma medication ratio, which is a HEDIS quality metric that is associated with asthma-related ED visits as well. And those information are provided to the given to the providers so they can gauge where they stand and they can make informed decisions as to how to adjust their intervention patterns. And to the right, it's just some key information about what providers have done with these reports when they receive them. One workflow integration, like Cesar said, we would support providers in how they adapt and integrate these reports into their clinical workflows. At Parkland, we do have a point of care alert in the EHR database on these for patients who are very high or high risk. Some providers have used this to prioritize scheduling, including things like telehealth. Some providers have used this to prioritize spirometry, allergy testing, targeted case management, and community health worker interventions, medication management. Those are all key aspects of asthma care. And this is important because on a population level, if we wanted to do everything for everybody, it wouldn't be doable, but with a listing or a risk stratification, one can then target these interventions fairly specifically to a subgroup of patients. Next, please. And the text messaging program. So this is a key important aspect because for every chronic disease, we know an informed patient is our preferred, our better partner. So we build a text messaging program that leverages information from validated tools, but then break those down into short messages. Patients receive 2 to 3 educational messages per week, but then, like Cesar said, a short asthma, 2-item asthma symptom survey. One is actually an asthma symptom survey, and the other one is a medication adherence survey, and they receive it once to twice a week. Once a week, if their asthma symptoms are fairly well controlled, then they will receive it weekly only. But if their asthma symptoms are reported to be poorly controlled, then they receive a repeat survey within 48 hours just to ensure that these symptoms are persistent. And if those symptoms are persistent, then that report is packaged and shared with providers on a bi-weekly basis so that they have that information at hand in addition to the risk prediction model that we've built. And then we have a 3RM satisfaction survey that we send out to patients one time every 3 months. We monitor the impact both quantitatively and qualitatively of all these interventions. Next, please. So the program evaluation is just to give you a sense of the framework for evaluation. We have had, we started this model, asthma, AI-driven asthma model with the Parkland Community Health Plan, which is a Medicaid managed care organization. We started it in 2016, and then we rolled it into the CHNA program, the EHR-based model, in 2020. And the approach to evaluating the program is to monitor it on an annual basis. And it's a quasi-experimental design because everybody is welcome into the program, but then we still need to have some level of control to ensure that what we're monitoring reasonably attributable to the program and not to some temporal changes in the overall population. And then we specifically measure the impact of the text messaging program because it is one of those aspects of the program that we do have a control over that is fairly isolated. The data sources here for the PCHP program were claims data and the Hospital Council, DFW Hospital Council data. Just W Hospital Council is a regional data aggregator that serves more or less a function of a health information exchange platform. And for the CHNA program, we leverage Parkland EHR data as well as the Hospital Council data set. And again, this is important because Parkland does not have a dedicated pediatric asthma emergency room, pediatric emergency room. So many patients from Parkland will end up in other emergency rooms. Having HIE data is essential to be able to monitor those outcomes. And the outcomes of interest here were, as a primary outcome, a rolling 12-month asthma-related ED visit rate. And asthma-related ED visit is defined fairly stringently as any ED visit with asthma as a primary diagnosis. And then secondary outcomes are hospitalization, systemic steroid use, outpatient visits, asthma medication use, and then the qualitative outcome from the text messaging program satisfaction survey. And to the right is just to show you how the rolling 12 months evaluation works for it as a window is basically sliding forward. Next, please. So a few outcomes. So this is truly a summary outcome for the PCHP program, which was the inception to the CHNA program. We stratify about 25,000 patients every year. And within the first year of implementation from 2016 through to 2017 through 2020, we had a 42% drop in, noticed a 42% drop in asthma-related ED visits. And you can see in light green, the PCHP trends, they started up higher than the non-PCHP patients, and then they trended down, while this, the PCHP patients, the non-PCHP patients trended down, but then remained more stable. So that difference was persistent across program implementation. And then we also looked at cost analysis, but this is PCHP patients only because the HIE doesn't give us cost data. They do give us charges, but charges are not really comparable to cost. We could see a 32% drop in asthma-related cost for PCHP members who participated in the program. Next, please. Then diving more into the CHNA program, which is the program that we're modeling our MHI application on. So here, looking at Parkland patients only, we stratified close to 5,000 patients over the 2 years or 3 years program implementation that are part of this report. 2,500 of them were enrolled in text messaging program. And in a nutshell, we observed a 36% reduction in asthma-related ED visits. But the next slide is going to give you some more detail on that. So as you can see in on the figure to the left, you could see that pre-implementation, Parkland in orange and control groups in blue, and the control groups again are patients from the HIE that are not Parkland patients. So what you could see is that pre-implementation, Parkland's ED visit rates related to asthma were going up, and the control group were basically going down. But as the implementation started from 2021 through 2023, you can see a steady decline into asthma-related ED visits for the Parkland group, when you can see that it's fairly stable, the ED visit rates are fairly stable for the remaining groups. So the reversal in ED visit trends, in addition to the actual drop, is a fairly robust signal that the program might be working out. As you can see, the pandemic period is embedded in that evaluation time frame, but the fact that we have a control hopefully helps control for pandemic effect. While we didn't see any significant changes in asthma-related hospital admissions, and we didn't have medication or cost data for control patients, so we couldn't perform a comparative analysis there. Next, please. So looking specifically at the text messaging program, comparing participants versus controls, you could see that within 6 months of enrollment, and for the text messaging program, we actually looked specifically at, we took every patient on their enrollment time and we monitored them over 12 months. And we could see that within the first 6 months of enrollment, you had a significant improvement in trends in asthma-related ED visit with 36% drop. The green is the treatment group versus the control group, where you actually have a slight increase in the trend in asthma-related ED visit, and that was statistically significant. As for asthma-related hospitalization, you could see that the trends, although trending slightly down and then up for the treatment group, the trend was actually steeper. The uptrend was steeper for the control group. There was a 60% drop in asthma-related hospitalization, but this difference wasn't statistically significant because hospitalizations are a fairly rare event, and therefore numbers there can be fairly unstable. So looking at asthma-related systemic steroid use, we saw a 59% drop in asthma-related systemic steroid use among controls, treatments versus control groups. And we also looked at asthma-related costs, well, subset of patients that are PCHP, and we had a 24% drop in cost within 6 months of intervention, as you can see from the pre versus the post, and these are matched cohorts, so we made sure that they were fairly similar at baseline in terms of their asthma or asthma potential asthma risk drivers. Next, please.
So we did get, as mentioned, you all mentioned, we did have qualitative feedback on how the program worked for those who enrolled in text messaging. And you could see that about 83% of those families that enrolled felt that as a result of the program, their child's asthma was better controlled. And about 92% said that they would recommend the program to friends and family. And about 84% felt that this program taught them how to better take care of their child's asthma. Because as a reminder, they would also receive text messages with education tagged to the text messaging. So this is a slide. This is just a visual of what the text messaging would look like. If you would like, corporate communications actually made an Instagram video of a patient testimonial of how she utilized the program. So so you can look at that if you would like. She has 3 children. Her youngest 2 have asthma that are well controlled. It's a nice story. Her oldest child actually grew up in the Parkland system. Now she is a first-year medical student at Texas A&M Medical University. So a lot of success stories in our clinic that take place. So thanks to Kaiser Permanente, we would also like to implement this program in other healthcare settings. There are 2 FQHCs in Dallas. Foremost is a clinic that is not far from where I practice, and it's in South Dallas, and it serves a predominantly African American population. Los Barrios Unidos is a clinic in West Dallas that serves a predominantly Hispanic population. So it's different healthcare setting, different EHRs, different processes that take place. So what we're hoping is that if we could institute the same program in a different setting, how successful can we be, and would we be able to have as much success of what we are doing in the large public academic setting of Parkland Hospital? So this just quickly is a timeline of what we aspire to. We're hoping that in January 2026, we'll be up and running in these 2 other clinics. We are currently in months 1 to 6, so we are undergoing things such as IRB approval. We're getting MOU and legal agreements with the different organizations. We're trying to work through the different compatibilities with different EHRs. But we're hoping that where we're starting now will eventually lead to production in 2 years. And this another tool that was developed that was not, it's not a patient-facing tool, but it's actually a community-facing dashboard that we created. And basically what we tried to do is we tried to create an asthma heat map, taking all of the SDOH factors that we had thought about and described. We took very different variables, and we tried to overlay it geographically onto a pediatric heat map. And as you can see, the most highest risk for pediatric vulnerability to asthma attack are in the dark green and the blue sections, and you can see that it matches kind of what we found with our community health needs assessment. So once again, South Dallas, Southeast Dallas, and what are the areas that show the most vulnerability for asthma attack. And what we're trying to do is that we're hoping on a high level, what can we do to target interventions in our community to have an effect on pediatric asthma? And so one place that we're starting is we're trying to institute something called Asthma 411. And some of you might know about this program. It was actually passed by the Texas legislature, and it allows for school nurses to administer albuterol to students who come into the clinic who do not necessarily have a letter on file or a prescription on file that the student has asthma, and that the student can be given albuterol. This is something that's already taking place in Fort Worth. And in Fort Worth, they're implementing this, and so far they've had good outcomes. Nurses get training, and they're given a clinical algorithm of who goes to the ER, who goes back to class. And what has been shown is that a lot of these children can be sent back to class, even though, a lot of these patients, they don't even know that they have asthma, but they might present to the nurse's office with a cough. So those are the kind of clinical settings that I think we can have a positive effect on. So anyways, the PASS system is something that we're using to target intervention in our community. Dr. Pengetzi has written a very good article about the system, and it's going to be published in the New England Journal of Medicine, Catalyst edition in August 2024. And you can actually see it online on July 17th. So you can, for further details on it, you can look for that online. That is our last slide. And so with that, I'd like to entertain questions by those out there, those online.
Yes, well, thank you both, Dr. Termulo and Pengetzi. I'm so terrible with names. I apologize. Pengetzi. Yes,
that's perfect.
Pengetzi.
Yeah.
Well, thank you so much for that wonderful presentation. One thing that is important in contextualizing this work is really understanding or considering some of the broader movements that are occurring in AI, specifically around responsible AI. And there's 3 main movements that I'd like to discuss or make sure that we emphasize. One is health equity by design. So ensuring that when we're deploying and we're designing our AI interventions, that we're doing it with health equity by design principles. The second is understanding AI lifecycle management. And there are some really great frameworks, including NIST's AI risk management framework that help to guide practitioners in adhering to AI lifecycle management principles. And the third is emerging regulatory frameworks, specifically, for example, ONC's HTI-1, which demands AI transparency within the electronic medical record, specifically targeted at EHR vendors, but definitely if our vendors are going to be providing information about their models, that really sets the stage for those internally developed models to similarly provide transparency about those models to their practitioners, to the clinicians that are deploying the model. And so to that extent, I wanted to ask a few questions around AI transparency, specifically around representation of the training data set, how you are planning on addressing stratified performance by subpopulation and fairness of the model by subpopulation. So we can start with describing how your approach when you're generalizing from, say, Parkland to the extended FQHC sites. How are you addressing representation in the training data set, as well as those performance metrics and fairness?
That's such a great question, Maya. I believe, and that's important to us because our goal is to bring AI into the safety net population. So by design, that is already an equity goal, making sure that these subpopulations that are typically left out of innovation and usually are a second thought should be a forethought. We should be designing things that address their specific needs. So the selection of our partners, our FQHC partner, was very much driven by making sure we have representation. We know that both are going to address low-income populations, but we want to make sure that within those low-income populations we identified, we have a good representation of specific racial, ethnic minority groups that, again, are traditionally left out of AI. So the selection of partners is one of the key aspects to ensure that this model is generalized to the right population. The second is I believe this is best practice for model generalization, is when you bring a model in, can't just implement it as is. Need to test it, make sure that it functions optimally, optimize it as needed so that it represents the actual issues of the populations for which the model is being run. So when we bring in the model, our plan is to test the model, retrain it, update it so that it represents the risk factors that are inherent and specific to the populations that we're addressing, we're targeting with it. And the third aspect is monitoring of model performance and model outcomes. And we have a specific subset analysis that will be monitoring not only model performance, but program impact by racial and ethnic groups. Because again, it's one thing to run a model, it's something else to make sure that the interventions are equitably implemented across groups. We're always very wary of any outcomes that is the central measures, right? Averages, means, they're fantastic. Only they can obscure huge problems with disparities. So in this case, we are going to be looking specifically as how the model works in specific racial, ethnic subpopulations, the Black populations, the Latino population, but also socioeconomically disadvantaged subgroups.
Wonderful. That's a great, all great plans, and which really should be a standard, right? That should be how all models that attempt to generalize to other populations really make sure that they are doing that fine tuning for that community and measuring both the stratified performance and the outcomes, because it's really the outcomes that are so important. And so there's actually a question from one of our audience members. They ask, would you share your thoughts on how this model can be populated nationally quicker? So is there a way to, if it's successful in FQHCs within the Dallas area, is it possible to accelerate that generalizability quicker? What are the challenges? What are the risks? And do you wish to have that every hospital across the US and even globe take advantage of this model? What would that look like?
Well, I can say,
Termulo, sorry, can you unshare the screen so we can focus
oh,
the discussion
sorry.
on the panel? Yes, I just wanted to make sure. Yes, thank you.
Okay, sorry about that. Well, I just from the Parkland perspective, I wanted to say that I think, I think the most important thing is to be able to have data experts who can partner with you to be able to institute this kind of a model. Because, for myself, if I'm definitely not a data expert, and I leave almost like all of that up to Yolanda and her team. So I think one important thing is to be able to have a system that can utilize technology and have people that can specialize in technology, and run these risk predictive models and reports and program that. And I think that is a major issue, because we have to have systems that would be able to devote resources into such to such an initiative. Because I know for Parkland, we don't have as many resources as we would like, but luckily we do have PCCI that we can partner with.
I agree. Thank you, Cesar. And I would say to supplement Cesar's that that's our goal. Our role is to facilitate the generalizability of this model. And we're really hoping that this specific grant gives us robust insights into what it takes to generalize the model. We already have a plan in place, but as we know, plans are meant to fail. So we know we're going to learn things from some specific changes that will happen. We've already started learning quite a bit about, some of the steps it takes to even get to the point of even starting to test these models, right? One of the key learnings that we've had so far is the fact that, and this is something that's important to understand, FQHC data might be missing from health information exchanges if there are some specific barriers that they have to go through to send their data in there. Those are key safety net systems, but their data may not end up as such into health information exchanges. So one of the things that we've done is we've leveraged Parkland's relationship with our health information exchange platform to access at least the data from these patients when they go outside of their system into other systems that are sending data into the health information exchange. So we are going to learn a lot from this implementation. And the primary goal here, as Parkland's primary goal, is to make sure that we make this available to the largest number of folks that can benefit from it. So that's a primary goal, and we hope this grant helps us. We hope in a few months, certainly by the end of the 2-year grant period, that we have some specific recommendations as to how we go from having it being a local internal Parkland model to a regional and eventually to a national model.
Well, that's wonderful. And that actually is a great to lead up to one of the questions that came through on my audience. And this is really around data sovereignty. You mentioned some of the challenges with FQHC data around health information exchanges. How are you, and this is actually like a smaller, like a pilot of how we address data sovereignty issues. How are you addressing it? And what do you see as barriers to scaling when you have all of these desperate, say, fiduciary responsible parties when it comes to data?
That's so true. Well, I think, and Dr. Termulo is probably going to be able to speak to that better than I do, but I think the number one barrier is, of course, the fact that the data is basically balkanized, right? It's siloed. Everybody has a piece of it, and everybody holds on to the piece of it that they have. And then there are privacy laws, which rightfully should prevent everybody to access every data, but which can also be leveraged used as a barrier to integrating all data. But one of the key pieces of activities that is helping us integrate the data across organization is partnership building. So ensuring that you create the specific partnership with the stakeholders and leverage those partnerships, not only for a program like this, but ensuring that it can be reused or reused for other interventions. So every stakeholder finds value into sharing data. When they do, it's so much easier to do it now. You still have to go through the legal hoops of, making those DUAs and MOUs and who knows what, but at the end of the day, once they are established, I would say we would have had a harder way getting into data access if we did not have pre-existing relationships with these partners. So I think creating those local partnerships within the region that your catchment region is important, so that when it comes time for data integration, it's not just a data integration thing, it's actually a partnership intervention that you're leveraging. Dr. Termulo, any additional thoughts on that?
Yeah, we and Dr. Bengesino was also that we had thought initially we would create a community-facing dashboard and a more patient-facing dashboard or provider-facing dashboard with specific data, patient data. We've not gotten to that point. I think there will be a lot of legal involvement to know what we would be able to publish on that website. So at this point, in terms of sovereignty, that it's, if you Google Dallas County Health Department and pediatric asthma, you'll have access to our past dashboard. You'll be able to see it because it's community facing. So all the data that we collect and all the data that we use in conferences and whatnot in summits that we offer this to the public because our hope is that we can use it on a higher level in terms of community advocacy, in terms of taking care of pediatric asthma.
Wonderful. And so the next question that really, again, continues out along the line of scaling and generalizability. In general, the path of least resistance has been to scale to other academic medical center peers. And that sort of, has been done. We do it all the time. Other than FQHCs, can you give examples of how you've been able to, or what you're considering on how to spread to other organization types?
Well, I would say, so all organization types, hopefully, the way we're scaling to FQHCs is basically the way to scale to smaller providers. So technically, if we are successful in scaling into FQHCs, it should be something that's replicable even to community providers or whatnot. But one experience we've had was with the Parkland Community Health Plan, because it is a health plan that has a provider network. We were able to implement their model across multiple different types of providers, from small provider clinics to larger provider groups that are not FQHCs, yet still target some specific subsets of populations. And what we found was that as long as there is a common goal that aligns between the mission of the provider and the mission, of course, of the health plan and the good of the community, there is a way to engage them. But then to expand to them, again, if it's claims-based data, you need to have access to claims data. But in this case, again, the fact that we make it EHR-based data makes it that if a provider has an EHR, the model is going to be potentially applicable to them. Now, some key aspects may not be, not all aspects of this model are going to be applicable to everybody. For instance, we're trying to build what we call point of care alerts. within the EHR so that the information is readily available to clinical provider while they're seeing patients. But some EHRs may not have that possibility, right? So depending on what EHR you use, we may not be able to build that in. But at least the fact that the program is multi-modular makes it that if you don't have that specific intervention, you still can do other things with the report. Which is truly one key aspect of this model in general, and of this of our approach to the AIM-High grant in particular. That is, we give leeway to each clinic to do design interventions based on what they think works for them. Now, it makes program analysis a little more complex on the back end, but it does make any finding much more robust, because that's real life implementation of these interventions. Every time you send an intervention to a patient, it's not controlled clinical trials. It is basically people using it the way they would use it optimally, and us assessing and seeing if it works. So I think that's actually one important part of evaluating these models, making sure that outside of control settings, they can still be leveraged to make some difference. That's one key aspect of what we're trying to analyze, and hopefully that makes it more generalizable to all types of providers.
Wonderful. And oh yes,
I
Cesar,
just add one more thing.
Yes,
I do think
please.
we are somewhat fortunate in that here we have somewhat of a fertile ground that we are able to accomplish this kind of a program, because those areas that have most vulnerability to asthma, Parkland has clinics in all those areas. So in terms of being able to have providers on the ground and it's not so compartmentalized as perhaps other cities might be. We are also fortunate that we work with a managed care organization, PCHP, that can easily share all of this data with us, and having PCCI. Those are some of the factors that allowed us to be successful in this. So I can see it might be, we'd be happy to share our experiences with others, but we do have a very fertile ground for this kind of a project.
Wonderful. So that actually leads nicely to this next question, which is a very pragmatic question around resourcing. You're always going to get the resourcing question, right? Like, depending on the type of health system, if it was a pure academic medical center, what would the resourcing be to generalize to their particular population? And then if it's another FQHC or a small clinic, what would the resourcing needs look like when it comes to data scientists, physician engagement, clinician engagement, community engagement? All of that is required resources to make this a successful intervention.
That's such a great question, and we do not have an answer to that as of now. But what we can say is that we truly don't expect FQHCs. So let me take a step back. When we started the program with PCHP in 2016, both Los Barrios Unidos and Foremost are part of the PCHP, the Parkland Community Health Plan Provider Network. So they received reports for their patients, and those two specific clinics reached out to us. And that's just to tell you, when we saw the AIM-High grant request for proposal, it was like a solution to a problem that we'd had for a while. So when we reached out to FQHCs, because they have that equity lens, the recurrent request from them was, well, this is great, it's working great, but only for a subset of our patients. How do we implement it to all of our patients? And we're like, well, we need to have access to the data that is necessary for those patients. We need to be able to pay for that implementation to happen, and then test and see if we can give you enough value that you can then roll back and find robust funding to support these implementation. 2016. So again, we started that project. So that is a question we had. So when we saw AIM-High, we're like, okay, so here comes the fund for that proof of concept that you needed to, one, generalize this to your population, and second, to ensure that it is implemented. So what I'm trying to say is that, unfortunately, some organizations are probably not going to have the standalone funds or resources that will be needed to implement these activities. However, on regional and potentially on a national level, it is important to think of equity as being able to enable these organizations to do these kinds of value-based intervention. And therefore, if they can't have those isolated resources, maybe provide them with the additional resources or the partnership or the collaborations they need to be able to implement these activities in these subsets of populations, and truly the value to direct value to the healthcare system and value to the society would justify some investment in that avenue. And I think Honor was very kind to engage all of us into writing a paper that we submitted for a review. I got some good feedback from it, but one of the key offerings here was the fact that it is important, if we want to generalize these models in an equitable way, to acknowledge that the fact that some people just might not have, some organizations just might not have standalone funds to have access to these information or in these interventions, and we need some additional support. And I'm not a policy person, but it seems to me that if we prove that this is helpful to the community, to the society, saves costs, and enhances quality of life, then it might be worth it thinking of supporting the least resourceful organizations in implementing AI among their population in a more meaningful way.
Yes, and I can tell you that Parkland has its own IT department, so we have a whole set of employees that will run our reports and such. PCCI is not our IT department. So we really have our IT department is full with all the things that we have done with our EMR refinements and such. So PCCI is somewhat separate. So once again, we're lucky to have someone like PCCI that can develop a report such as this and risk prediction models such as this, because I feel that our IT department would not be able to, because they have a lot on their plate. It's as it is just running our hospital.
Well, I definitely would like to thank you both. This has been incredible. First, congratulations on the incredible work you've already accomplished, and so looking forward to your ongoing work, especially around generalizability to FQHCs and being able to really set that standard on how to do that in a responsible way. So thank you both, and I'll pass it on to Honor to wrap us up.
Yes, thank you. This was a wonderful talk, and thank you for a wonderful discussion. Alicia, I think we can close up.
Yes, thank you so much. This was wonderful discussion, and thank you for coming and presenting. Yeah, I think some of those things resonated quite a bit, because these sessions are hosted in partnership with AIM High Initiative and Health AI Partnership. And at Health AI Partnership, we are trying to develop those best practices for AI lifecycle management, as well as for the practice network, that the cohort of sites that we are recruiting from FQHCs and other rural settings to test out scalability of such solutions and capabilities requirements. So thank you so much. I'll post links if people want to check our work out. Yeah, thank you. I'll hand it over to Caitlin, I think, for the next announcements. All right, I think this is the slide for the next symposium. I posted the links for registration on the chat as well on October 8th from 12:30 p.m. Pacific Standard Time and 3:30 Eastern. And we will send out the announcements to the Health AI Partnership and AIM High community as well. Thank you. Thank you.
Thank you for
Bye.
having us.
Thank you.
Thank you very much.